The term stigma is used throughout this presentation to represent the complex of attitudes, beliefs, behaviors, and structures that interact at different levels of society, groups, individuals, organizations, systems, and manifest in prejudicial attitudes about and discriminatory practices against people with mental and substance use disorders. Attention to stigmatizing structures of society, such as laws and regulations, enables examination of prejudice and discrimination against people with mental and substance use disorders. Discriminatory policies and practices can appear to endorse negative social norms and deepen self-stigma. This presentation will offer a brief overview of what is currently understood about stigma, including influential factors and consequences of stigma from the level of society as a whole to the experience of people with behavioral health disorders. Public norms and knowledge about people with mental and substance use disorders have been captured through population-based surveys with components focused on the stigma of mental and substance use disorders as it is reflected in stereotypes, help or treatment seeking, and behavioral dispositions. Results of an analysis of the National Comorbidity Survey replication that compared data from the early 1990s and early 2000s showed that stigma associated with mental health treatment decreased and support among the general public for treatment seeking increased. A survey of states in 2007 and 2009 showed that more than 80% of U.S. adults agreed that mental illness treatment is effective. People living in states with higher per capita expenditures on mental health services were more likely to agree that treatment is effective and were more likely to report receiving treatment. In 2014, the Substance Abuse and Mental Health Services Administration found that some common reasons reported for not receiving behavioral health care included the inability to afford the cost of care. That was about 48% of people. Believing that problems could be handled without treatment. That was about 26.5% of people. And then not knowing where to go for services. About 25% felt that way. There were also concerns about confidentiality from about 10% of that population. And it might cause neighbors or community to have a negative opinion. About 10% felt that way. 8% felt that it might cause a negative effect on a person's job. 10% felt fear of being committed. 6 to 9% felt inadequate or no coverage of mental health treatment. And about 9% thought that treatment wouldn't help. Now, comparing results of the 1996 General Social Survey, the GSS, stigma modules with those of surveys in the 1950s on U.S. attitudes about mental health or mental illness stigma showed that public knowledge about mental and substance use disorders increased, specifically as it related to the neurobiological underpinnings of these disorders. There was greater public awareness of the stigma associated with these disorders, but public stigma itself remained high. Results from the 2006 General Social Survey found greater sophistication in the public's knowledge of disorders and treatment than in the 1996 survey administration. But stigma levels for people with mental illness did not decrease over time. Results of the General Social Survey have shown that the level of public stigma varies along a gradient of social distance. In more intimate settings, the rate of stigma reflected as social rejection was higher. So, for example, a depressed person to marry into the family, there was about a 60.5% rejection rate versus the more distant move next door, which was about a 22.9 rejection rate. Stigma against children and adolescents was lower compared to that of adults and also varied with social distance, reporting higher rates of rejection for a friend with depression. That was about 29%. Than for a classmate with depression, which was about 11%. One half of all adult respondents said that treatment would result in discrimination and long-term negative effects on a child's future. Across countries surveyed in the Stigma in Global Context study, levels of recognition, acceptance of neurobiological causes of mental illness and substance use, and treatment endorsement were similarly high. However, a core of 5 prejudice items persisted. The researchers called this the backbone of stigma. Issues of trust in intimate settings, such as the family, potential contact with a vulnerable group, such as children, the potential for self-harm, mental illness being antithetical to power or authority, and uneasiness about how to interact with people with mental illness. And then finally, a review of studies of public stigma of mental illness, which included studies with variables related to substance use disorders, showed that over time, the proportion of Americans who endorsed neuroscientific views of schizophrenia and alcohol dependence has grown. Americans also have endorsed the use of physicians and prescription medication for these disorders in greater numbers and reported being more willing to discuss behavioral health difficulties with family and friends. However, the persistence of core prejudice factors help explain why increased public knowledge has not decreased public stigma. Core indicators of stigma remain higher for people with schizophrenia and substance use disorders than any other condition. Furthermore, the highly stigmatizing public perception of violence as a component of mental illness has not decreased over time. Societal structures reflect public norms and values, and many of the factors that influence structural stigma are the same as those that influence public stigma. Self-stigma occurs when a person with mental or substance use disorder internalizes negative stereotypes and the public and structural stigma directed at these disorders. Public perceptions and beliefs about mental and substance use disorders are reflected by knowledge about these disorders, the degree of contact or experience that one has had with people with mental and substance use disorders, and media portrayal of people with mental and substance use disorders, as well as media coverage of tragic events, notably gun violence and suicide. Public perceptions are also strongly influenced by social norms concerning the attribution of cause or blame for mental and substance use disorders and the perceived dangerousness or unpredictability of people with these disorders. Race, ethnicity, and culture are embedded in social relationships and, as such, play a role in shaping attitudes, beliefs, and behaviors. A biogenic model of the origins of mental and substance use disorders has been applied in an effort to reduce blame and promote positive attitudes about the value of treatment and the possibility of recovery. People with substance use disorders are generally considered to be more responsible for their conditions than people with depression, schizophrenia, or other psychiatric disorders. Beliefs that a substance misuser's illness is a result of the person's own behavior can also influence attitudes about the value and appropriateness of publicly funded alcohol and drug treatment services. There is a lack of empirical evidence supporting the stigma reducing benefits of a neurobiological conceptualization of psychiatric illness. Although some research suggests that attributing mental illness to biological causes may reduce the blame placed on individuals for their own behavior. Other research has shown that attributing behavior to a genetic cause can increase perceptions of the difference of people with the disorder and the persistence, seriousness, and possibly transmittability of mental illness. Overall, declaration of the brain disease model of addiction does not appear to have a reduced public stigma about substance use disorders and may decrease perceptions of self efficacy and ability to cope among people with behavioral health conditions. Americans are more likely to believe in the dangerousness of people with mental illness than are citizens of other developed, industrialized nations. In a recent national survey, 4 in 10 Americans believe that children and adolescents with depression were likely to be violent, and finding that may be related to media coverage of school shooting incidents. Stereotypes of violence and unpredictability are associated with higher levels of public stigma towards people with mental illness. People with substance use disorders are considered even more dangerous and unpredictable than those with schizophrenia or depression. In a survey conducted in the United States, a vast majority of respondents considered it likely for a cocaine or alcohol dependent person to hurt others. People are less likely to endorse the stereotype of violence if they have had direct contact with people who have mental and substance use disorders and have not experienced violent acts by people with these disorders. Stereotypes of dangerousness can influence public policy in terms of restricting the rights of persons with behavioral disorders. In the current context of the increasing frequency of mass shootings in the United States, beliefs about the dangerousness of persons with mental illness and substance use disorders have come to the forefront in public policy debates. To inform these debates, a review of epidemiological findings related to mental illness, gun violence, and suicide found that there is a greater relative risk of violence in people with mental illness than those without mental illness. But the risk is actually very small. The risk of violence is greater for people with schizophrenia, bipolar disorder, co occurring substance use disorder, and those exposed to certain socioeconomic factors like poverty, crime victimization, early life trauma, and a high neighborhood crime rate. People with substance use disorders and antisocial personality disorders have a higher risk of violence than people with other psychiatric disorders. The risk of suicide as another form of violence is increased by concurrent substance use. Symptoms such as hopelessness and depression, psychotic disorders, bipolar disorder, and environmental factors such as access to guns and media reporting of suicide. Swanson and colleagues point to the gaps in the knowledge based on the relationship between behavioral disorders, violence, suicide, and guns, as well as to the gaps in knowledge on effective policies to reduce gun violence and suicide. Knowledge about mental and substance use disorders can positively influence public norms. Yet, there is evidence that reframing these disorders as brain diseases produces mixed results on people's attitudes and behavior toward people with mental and substance disorders. Public education campaigns that frame mental and substance use disorders as brain diseases can have unintended consequences, including increased perception of difference and disbelief in the likelihood of recovery. People with substance use disorders, in particular, are viewed by the public as weak-willed, although evidence shows that they are as likely to adhere to treatment as people with other chronic medical conditions like hypertension or diabetes. Unfortunately, and in spite of efforts to educate the public, this misperception has increased over time, according to the findings from national surveys from about 1996 to 2006. Media portrayals of people with untreated or symptomatic substance use disorders, rather than depictions of those on a path to recovery, may be a factor in maintaining or increasing negative stereotypes and stigmatizing attitudes and beliefs about people with substance use disorders. Among healthcare workers, one consequence of bias against mental illness is the misattribution of physical symptoms of illness to concurrent mental disorders, as well as lower rates of referral by primary care practitioners to appropriate physical health services like mammography, cardiovascular procedures, and pain management. Healthcare practitioners outside fields of behavioral health also lack knowledge about mental illness, and there is evidence that can lead to misdiagnosis of both mental and physical conditions, and to selection of improper and inadequate treatment regimens. So in addition to the knowledge gaps, there's negative attitudes towards individuals who have mental or substance use disorders, and those are prevalent amongst healthcare providers. So for example, although high remission rates for alcohol dependence have been found in population-based studies, many healthcare professionals continue to view alcoholism as incurable. There was one study, nurses' self-reported lack of knowledge related to behavioral health. It was associated with greater reported fear and avoidance of people with mental illness, demonstrating the link between lack of knowledge and the holding of prejudicial beliefs. Conversely, emergency room staff who reported having skills in treating these disorders held more positive views about the possibility of recovery than those who did not report having these skills. People's immediate social networks and the extent of their contact with people with mental illness affect their understanding of and opinions about mental illness in general. However, increased contact with people with mental illness doesn't necessarily reduce stigmatizing beliefs. And some studies have found that contact with people with substance use disorders raise the level of stigma. Among healthcare professionals, negative attitudes toward people with substance use disorders increased over time, during which they would have had more contact with people with those disorders. Several factors may explain why contact with people with mental and substance use disorders sometimes deepens the stigma, including the affected individual's symptom severity and stage of recovery. And in the context of contact based interventions, the quality of the intervention itself, the fidelity with which it was implemented, and the quality of the peer training that had been provided to the individuals offering the contact services. There was a study where medical students in Australia reported more positive attitudes about illicit drug users after they experienced contact with them in small group settings. There was a qualitative study where pharmacists and drug users in a needle exchange program in the United Kingdom, both groups reported a decreased sense of stigma with increasing contact and familiarity. There was also a review of two similar studies found that college students for whom at least 50% of their friends used drugs scored lower on a measure of public stigma. And then in another study, people who had a family member with an alcohol use disorder reported lower levels of stigma toward alcohol users than those without a diagnosed family member. A lower level of stigma does not imply support for the substance misuse, okay? Rather, it reflects more positive attitudes toward people with substance use disorder. It is important to say that despite these variations in outcome, the bulk of available evidence suggests that there is a strong and consistent inverse relationship between contact as an intervention and the level of stigma. More contact with people with mental and substance use disorders is associated with lower levels of stigma related to these disorders. The media provide ideas about and images of behavioral health that influence public attitudes, beliefs, and behaviors toward people with mental and substance use disorders. An example of the role of media comes from a study of mainstream publications. This study is from 1998 and it went on to 2008. And that covered the topic of postpartum depression and other mental illnesses. The test of communication theories showed that the media's portrayal helped shape the public's opinions about postpartum depression, and that when the attention given to postpartum depression and other types of mental illness was negative, public opinion tended to mirror negative perceptions. Much of the evidence on the media's influence on stigma change is negative in direction. The media plays a crucial role in stoking fear and intensifying the perceived dangers of persons with substance use disorder. So similarly, media portrayals of people with mental illness are often violent, which promotes associations of mental illness with dangerousness and crime. And going further, the media often depicts treatment as unhelpful and portray pessimistic views of illness management and the possibility of recovery. There has to be some positive change. An analysis of newspaper articles, and this is going back from like 1999 and 1989 and 1999, showed more coverage of issues related to stigma and mental health insurance parity in 1999 than in 1989. That analysis also found that there were fewer articles that contained themes of dangerousness and negative tones in 1999 than in 1989. However, even in 1999, articles with themes of danger and negative tones were still more prevalent than the positive themes in reported stories that included a focus on mental illness. Another content analysis of a nationally representative sample from the U.S. News coverage of mental health issues found that in 39% of the stories, an association was made between persons with mental illness and dangerousness. Treatment was discussed in 26% of the stories, but only 16% of the stories included recovery as an outcome. Moreover, recent research suggests that given the broad reach of U.S. media, the volume and intensity of negative coverage about mental and substance use disorders are increasing mental health stigma in other countries as well. Studies of new social media, experimental studies, and evaluations of anti-stigma initiatives point to the potential value and capacity of the media to counter stigma. So, for example, in a study of tweets comparing the use of words that refer to schizophrenia and diabetes, researchers found that tweets about schizophrenia were more likely to be negative, medically inappropriate, and sarcastic than tweets about diabetes. But their results also suggested that public misinformation could also be a target for anti-stigma efforts targeted at young people. Media reporting of suicide can be stigmatizing through selective reporting on homicides and suicides, especially celebrity suicides. But they can also be platforms for prevention by providing positive messages about available support and resources, coping, mastering personal crises, and the value of help seeking. There's one study of social media reactions to an attempted suicide that showed that a greater proportion of microblogs expressed caring, empathy, or calling for help, and that was about 37%, than posts that were cynical or indifferent. More research is needed to identify effective strategies that combine media, education, and support for help seeking. In a experimental study that compared attitudinal outcomes, researchers found that stories of recovery decreased prejudiced attitudes toward people with mental illness and drug addiction and increased belief in treatment efficacy. Australia had this Beyond Blue campaign, which was a comprehensive social marketing campaign to destigmatize depression. That provides another example of the impact of positive portrayals of mental illness. Check it out. This campaign, the researchers assessed an increase in understanding of depression, an awareness of discrimination, and self-reported use of mental health treatment. Socio-demographic characteristics have been found to affect a large number of social beliefs, but when applied to stigma, the research findings have been unclear. It's also important to know that the effect of socio-demographic characteristics differ depending on whether one is looking at the stigmatizer or the stigmatized person. Research is clearer on the relationship between culture, race, and ethnicity, and the quality of care that people receive. Ethnic and racial minorities access mental health care at a lower rate than white people, and when they do, the care they receive is often suboptimal. Several factors influence access, quality of care, and rates of treatment for mental disorders among ethnic and racial minorities and immigrant groups. Quality of care is compromised by language barriers and provider misunderstanding of cultural ideas about illness, health, and treatment. Although most healthcare professionals agree that cultural competency training is important, lack of cultural awareness remains a problem in many healthcare settings. Provision of physical and behavioral health services in integrated care settings has been shown to increase participation in mental health treatment for racial and ethnic minorities. So let's move on to the consequences of stigma. And so here I'm going to be talking about the three main types of stigma and the consequences that result from each. So I'm going to start with structural stigma. Now, the research on structural stigma is still in a developmental phase and constantly evolving. And the research that has been done focuses primarily on mental illness rather than substance use disorder. Now, while there is an overlap between structural and public stigma, it is possible to define and distinguish between these phenomena. So, structural stigma is the societal and institutional manifestation of the attitudes, beliefs, and behaviors that create and perpetuate prejudice and discrimination. All right, so to use examples of like persistent prejudice and discrimination in public and private institutions. I'll get into some government and legal system things, employers, and different things like that. So, public and private institutions, okay? One approach to operationalizing measurements of structural stigma has been through review of policies explicitly targeted at people with mental illness. There has been a review of legislation in all 50 states that found legal restrictions for people with mental illness in the following 5 domains: serving on a jury, voting, holding political office, parental custody rights, and marriage. There was a similar review of nearly 1,000 mental health related proposed bills, and this is back in 2002, that found that 3% restricted liberties, 1% were discriminatory, and 4% reduced privacy. Now, although the National Alliance on Mental Illness described many states' mental health systems as being in despair, their report on state legislation in 2014 documented increased activity on mental health issues. So, for example, in 7 states, legislation was enacted to protect the rights of individuals who are civilly committed, to clarify and improve civil commitment proceedings, and to encourage community-based court-ordered treatment. But ironically, although much attention focuses on the dangerousness and violence of people with mental illness, numerous studies have found that they are at a higher risk of victimization and of experiencing unfair treatment by authorities when they attempt to report crimes than people without mental illness. Poor legal outcomes are also observed among plaintiffs with mental illness in employment discrimination suits in comparison with plaintiffs without mental illness. People with mental illnesses are likely to experience housing and employment discrimination and homelessness than people without mental illness. 2 overt and well-documented manifestations of structural stigma against people with mental illnesses are segregated housing, some resembling psychiatric institutions, and community-wide rejection of mental health facilities. Some supported housing programs also have strict rules that people with mental illnesses must observe to maintain housing assistance, including prohibition of family or visitors and mandatory compliance with program requirements or medication regimens. People with mental illnesses are more likely than others to be counseled to accept a job for which they are overqualified, and they often face increased scrutiny by social workers, educators, physicians, family court administrators, and child protective services personnel. On a positive note, if there ever was one, the National NAMI's 2014 review of the state legislation found examples of states addressing the housing discrimination by enacting rules prohibiting homelessness and emergency shelters from refusing services to persons with mental illness and providing funds for home ownership to families of children with disability. The NAMI report also documented efforts in some states to increase funding for or make improvements to support employment programs. In the other arena of higher education, the Americans with Disability Act and other federal disability laws prohibit discrimination against students with psychiatric disabilities and require that colleges and universities provide them with reasonable accommodations. So, for example, they may receive a lighter course load or extended deadlines. But unfortunately, in U.S. universities, fewer than 1 in 4 students with a mental illness will seek treatment or other supportive services. A study of factors that inhibited disclosure of mental illness found that these included a high level of self-stigma, fear of future discrimination, having few positive relationships, and sexual minority and Caucasian identity. Previous contact with mental health service users and belief in the effectiveness of treatment were associated with greater likelihood of disclosure and help seeking. Another survey. This is a campus experience, and it showed that college students with mental illness reported less social engagement and fewer relationships on campus than the general population, and felt that they were treated differently most of the time. These factors were, in turn, associated with lower graduation rates than the general student population. Research that targets younger populations indicated that earlier experiences have already winnowed down this population, documenting reduced high school graduation rates and lower application rates to higher education. Even when students with mental and or substance use disorders do seek treatment, they often receive inadequate services, experience delays in obtaining supportive services. They may even face segregation from other students and receive harsher academic discipline than other students. Although much of the research that I previously talked about refer to people with mental illness. So people with substance use disorders, they also experience structural and discrimination in many forms. There was a national survey of people in recovery from alcohol and drug problems and their families, and it documented barriers to treatment, such as lack of insurance and trouble obtaining insurance, the cost of treatment, and lack of access to treatment programs. They also reported fear of discrimination at work and previous experiences of being denied a job or promotion. Despite the hurdles people with substance use disorders face, the implementation of legislation such as the ADA and awarding of federal disability benefits can be more restrictive for people with substance use disorders than those with mental illness. Stigma in the U.S. healthcare system contributes to disparities in funding for research and treatment of mental disorders in comparison with physical disorders, and to the negative attitudes, beliefs, and behaviors of healthcare professionals towards people with mental and substance use disorders. Structural stigma is manifested in the healthcare system in the low quality of care for people with mental and substance use disorders and the limited access to behavioral health treatment and other services. A fragmented bureaucracy for accessing behavioral health treatment, overuse of coercive approaches to care, and inadequate funding compared with that for physical care. Parity laws for mental and substance use disorder in the United States have become a cornerstone for efforts to combat the structural inequity of behavioral health coverage versus physical health coverage, and to eliminate or reduce coverage restrictions so that behavioral health benefits equate with benefits related to physical health services. States with behavioral health parity laws have higher utilization of services among people working for small employers and those in low-income groups. But unfortunately, increased access to care does not necessarily mean increased access to high-quality care or evidence-based treatment. Recent efforts to address structural stigma in the healthcare system through parity laws have been accompanied by evolving public attitudes regarding behavioral health in the United States. So there was this 2015 Harris poll that found that close to 90% of U.S. adults surveyed considered their mental health and physical health to be equally important. But 56% reported that physical health is treated more importantly than mental health in the current healthcare system. And then almost 33% thought that there were barriers to mental health in terms of accessibility and cost. Then, from a 2013 survey, 76% of adults thought that all healthcare plans in the United States should be required to include coverage for mental health care. Structural stigma may also be reflected in the deprioritization and lower levels of funding for behavioral health services and research compared to general physical health services and research. Despite the high prevalence of these disorders in the United States and evidence of comparable return on investment, research on mental and substance use disorders receive less scientific funding than on physical health conditions. Inadequate investment in behavioral health services research also reduces the availability of evidence-based services, especially in facilities that provide care to the safety net population. Quality measurements of behavioral health care amount to only a fraction of physical health care measures, and many are narrowly focused, kind of poorly defined, or lacking evidence, validation, and meaningfulness. There's a low reimbursements are also a factor contributing to the small percentage of psychiatrists who accept insurance and to the persistence of areas with shortages of mental health providers. Even with the availability of providers and insurance coverage, insurance benefits have traditionally been more prohibitive of behavioral health care services than physical health services. So, for example, by imposing constraints such as higher deductibles or requiring patients' mental health status to deteriorate before treatment coverage is allowed. Ridiculous, I know. So, as for the criminal justice systems, structural stigma is apparent in several areas related to the criminal justice system. The disproportionate representation of people with mental illness with criminal justice involvement and their treatment within the criminal justice system may be indicators of how criminal laws are designed and enforced in such a way as to differentially target and adversely affect people with mental illness. Nationally, more than one half of jail and prison inmates in 2005 had mental health problems. Incarcerated individuals with mental illness were more likely to have experienced multiple arrests and incarcerations, and only 1 in 3 people with mental health problems in prisons and less than 1 in 5 of those in jails access treatment since their imprisonment. Most U.S. states have more people with mental illness in prisons or jails than in state-operated psychiatric hospitals. To counter these trends, 11 states passed legislation in 2014 to halt the inappropriate flow of people with mental illness into the criminal justice system. Strategies included, for example, increasing training programs for law enforcement officers, examining arrests of people with mental illness, and developing diversion programs, addressing court systems' responses to people with mental illness, and establishing county-level mental health courts. Back in 2004, Congress authorized the Justice and Mental Health Collaboration Program through the Mentally Offender Treatment and Crime Reduction Act. It's a grant program to help states, local governments, and tribal organizations improve responses to people with mental illness in the criminal justice system through collaboration of efforts among the criminal justice, juvenile justice, and mental health and substance use treatment systems. Reauthorized for an additional 5 years in 2008, at that time, the act was then expanded to address law enforcement responses. In correction systems, whether prisons or jail, people with mental illness are more frequently abused by staff and inmates, more likely to receive sanctions like solitary confinement. They are given longer sentences and more often denied parole than inmates without mental illness. While under community supervision, people with mental illness experience more intense supervision and face a higher likelihood of receiving technical violations than others under supervision, even though the rate of new offenses is similar between people with and without mental illness. The complex relationship between substance use and criminal behavior is beyond the scope of this presentation. However, in terms of structural stigma, it is important to note that institutional policies that treat substance use disorder primarily as a criminal issue rather than a health concern they promote a stigmatizing environment, and that includes and marginalizes that it excludes and marginalizes people with substance use disorders. Anti-drug messages and harsh criminal sentences for drug use appear to label people with these disorders as unwanted by society. Thus, the social processes designed to control substance misuse may actually promote its continuation by increasing the shame and deepen the public and structural stigmatization of this population. So, public stigma. This refers to the attitudes of the general public and also to attitudes of subgroups, such as first responders or clergy, that may have norms that differ from the general public or other social groups. Public stigma persists in part because structural stigma in the form of laws, regulations, and policies appears to endorse prejudice and discrimination against people with behavioral health disorder. There was a systematic review that identified 36 articles published over the last 25 years that reported on results from population-based studies of public stigma in the United States. Many of the articles were secondary analysis of findings from national surveys, including the National Comorbidity Survey Replication and the GSS's National Stigma Survey or Stigma Study. These surveys examined public stigma toward people with a broad array of disorders, and that included adults with depression, schizophrenia, alcohol or drug dependency, and children with depression, attention deficit hyperactivity disorder, and oppositional defiant disorder. The results of that review confirmed by other researchers indicated that public stigma leads to social segregation as well as diminished self-efficacy in people with mental and substance use disorders. Stigmatizing beliefs about the competency of people with mental illness compromise these individuals' financial autonomy, restrict opportunities, and may lead to coercive treatment, such as mandatory participation in treatment. Despite the importance of social support for the recovery of those with substance use disorders, stigma instead contributes to social exclusion. Also, it's important to know that stigma may affect not only the substance user, but his or her family members and friends as well. Over time, in both the United States and in other countries, knowledge about mental and substance use disorder, it's constantly increasing, but issues related to social exclusion also remain high. And lastly, it's self-stigma. So, as people with mental and substance use disorders become aware of public stigma and of related discriminatory practice, they tend to internalize the perceived stigma and apply it to themselves. The effect of self-stigma include lowered self-esteem, decreased self-efficacy, and psychologically harmful feelings of embarrassment and shame. Low self-esteem and low self-efficacy can lead to what's been referred to as the why try effect, meaning Why should a person try to live and work independently if he or she is not valued? Among people with mental and substance use disorders, low self efficacy is associated with failure to pursue work or independent living. A greater degree of self esteem is associated with goal attainment, quality of life, and help seeking behavior. A substantial body of research has shown that there is a negative relationship between stigma and help seeking. Self stigma can also be a barrier to recovery and community integration. People who have disclosed their experiences report lower level of self stigma. In a systematic review of research published between 1980 and 2011, which examined the associations between mental health related stigma and help seeking for mental health problems, it found that stigma related to fears about the consequences of disclosure was the fourth highest ranked barrier to help seeking. Members of racial and ethnic minority, youth, men, military service members, and health professionals were disproportionately deterred from seeking help by fears of being stigmatized. In addition, the level of public stigma shaped by both reported experiences of stigma, self-stigma, and an unwillingness to use services. Stigma against children and adolescents is a serious concern because of its negative impacts, including decreased feelings of self-worth and a willingness to enter treatment, and because of the harmful long-term effects of untreated mental or substance use disorders. Compared with the adult population, stigma against children with mental disorders is less well studied. A 2010 review of studies of stigma related to childhood mental disorders concluded that stigma research lacked conceptual underpinnings and that the evidence base was quite sparse. The National Stigma Study, this is the children's version, which was the first to include a nationally representative sample of participants to examine public stigma of childhood mental disorders, specifically focused on attention deficit, hyperactivity disorder, and depression, comparing public attitudes and knowledge of these disorders with asthma or daily troubles. One set of analysis showed that 81% of the adult samples perceived children with depression to be dangerous to themselves or others, compared with children who had asthma or daily troubles. A smaller but substantial portion, which was about 33%, also perceived children with ADHD to be dangerous. Large proportions of the sample thought that children and adolescents with mental health problems would likely experience rejection at school, and that was about 45%. And would experience, about 43% thought that they would experience stigma into adulthood. Many respondents also had negative views of the benefits of medication. The researchers concluded that some public beliefs about mental illness and treatment were based on a lack of accurate information and could present barriers for providers and for parents and others who seek treatment. A growing body of research focuses on young people's subjective experiences of stigma. Interviews with 56 adolescents in a Midwestern U.S. city found that 62% of youth experienced stigma with peers. 46% reported feeling stigmatized by their families, and 35% reported experiencing fear, dislike, avoidance, or an underestimation of their abilities by school staff. In a study of 40 adolescents who take psychiatric medication for a diagnosed mental illness, 90% reported experience of at least one stigma construct of secrecy, shame, and limited social interaction. The study also found that adolescents' perception of the norms of family members and school environments can increase their experience of stigma or protect against it. Results from a larger study of youth, and this was in Australia, suggested that using accurate psychiatric labels reduces stigma and may assist youth by reducing perceptions of weakness. The web-based injury statistics query and reporting system shows that suicide is the second leading cause of death among young people in the United States, aged 15 to 34. There is strong evidence that stigma is an impediment to help seeking on the part of young people and their families. Studies of family engagement in treatment have provided insight into how stigma poses barriers to care. There was a review of 12 qualitative studies in the UK on factors that facilitate or inhibit access and engagement in parenting programs for children with disruptive behavioral problems, which pointed to factors directly or indirectly related to stigma. Stigma was one of the factors that emerged as a prominent barrier to service from the perspective of both parents and professionals. So, in these studies, stigma was manifested as shame about needing help, perceived parental failure, and a fear of being labeled. Lack of information and lack of awareness about services were also major barriers to accessing care. Mainly from the professional's perspective, one of the main facilitators of access was effective advertisement and social service promotion using media, such as leaflets, posters in locations visited by parents, promotion on the internet, local newspapers, radio stations, newsletters, and parenting forums. And then lastly, I just want to go over potential targets and interventions to address stigma. So, targets of structural stigma would include things like legislators, institutions, and policymakers of systems and organizations that fund and regulate the places and situation where discrimination, lack of opportunities, and lack of access to quality treatment persists. The interventions that would be appropriate for this level would be legal, policy, advocacy, and professional education strategies. And then those strategies would be aimed at changing decision-making processes, policies, and regulations that support discrimination against people with mental and substance use disorders. Targets for interventions to reduce public stigma would include the general public and landlords, employers, healthcare providers, and groups within the criminal justice system. The corresponding interventions would be aimed at changing behaviors and interactions from discrimination, fear, neglect, and sometimes abuse to extending support, high quality treatment, and equal opportunities for housing, employment, and personal success. Examples of these type of interventions would be use of media for mass messaging to dispel myths regarding behavioral health disorders and treatment, education to counter the lack of knowledge about disorders and treatment, contact with people with behavioral health disorders, and protest strategies against discrimination. The general effects of stigma and the why try effect may be diminished by interventions that target individuals with behavioral disorders. So, the type of interventions would focus on promoting self-esteem and self-efficacy, empowerment through peer support, mentoring, and education to dispel the myths. Dispelling the myths is important, and increase social and coping skills. And of course, education to encourage treatment engagement. Treatment engagement is significant because evidence-based treatments have been shown to facilitate recovery by promoting behavior barriers, such as symptom monitoring, continuing to take prescribed medications, and seeking out supported employment opportunities, and by encouraging family interventions, increasing skills related to illness management, and promoting entry into integrated treatment for mental and substance use disorders. So, for many individuals, disclosure may be the initial step in the process of reducing self stigma when it can be done in a safe and strategic manner. And of course, as for the public, education, 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 talking about it, discussion and discourse, education, discussion, and discourse. We have reached the end of this presentation about stigma. Now let's reflect and discuss. So the first question is, how has stigma, either public or self-imposed, affected your willingness to seek treatment or support, and what strategies have you used to overcome these barriers? Secondly, in what ways have you experienced discrimination or fear related to mental health or substance use? And how do you think society's attitudes could change to create more understanding and support? And lastly, what role do you think sharing your experiences with others in your life can play in reducing stigma and promoting a more positive self-view?